Hi, I'm Dr. Michael Levy. I'm a gastroenterologist and professor of medicine at the Mayo Clinic. I was asked by the editors of Gastroenterology to discuss a paper being published in the May issue. Our study's titled Comparison of Methods to Detect Neoplasia in Patients Undergoing Endoscopic Ultrasound-Guided Fine Needle Aspiration. Endoscopic ultrasound, or EUS, is an essential component for the diagnosis and staging of a variety of gastrointestinal and other disorders. Performing fine needle aspiration at the time of endoscopic ultrasound increases the diagnostic sensitivity, it improves the staging accuracy, and enhances prognostic determination. The limited diagnostic sensitivity of EUS FNA often mandates the need for additional FNA passes. The result is an increase in procedure time, medication use, personnel needs, a decrease in room efficiency, and it may also heighten the risk of the procedure. These limitations have driven the pursuit for new technologies, and the use of molecular markers may help in this regard. Digital image analysis, or DIA, and fluorescence in situ hybridization, or FISH, are newly developed techniques that assess the nuclear DNA content in the presence of aneuploidy or tetraploidy to diagnose malignancy or neoplasia. DIA quantifies the cellular constituents using spectrophotometry. A Fulgen dye is used to stain the DNA. A video camera captures the transmitted light. The absorption values are converted into pixels of color, and a computer analysis of the pixels produces a digital image of the nucleus. Finally, a DNA histogram is created, which distinguishes the benign diploid from malignant aneuploid and tetraploid populations. FISH, on the other hand, utilizes fluorescently labeled DNA probes to detect the cells that have numerical or structural abnormalities indicative of malignancy. The probe set used targets centromeres of chromosomes 3, 7, 17, and band 9p21. Our group previously discovered the utility of DIA in FISH for diagnosing indeterminate bile duct strictures. In this study, we sought to prospectively determine the performance characteristics of DIA in FISH in patients undergoing EUS FNA. The first pass was randomized to either conventional cytology or DIA FISH analysis. Subsequent passes were alternated, and the DIA in FISH specimen was split, providing half as much material for analysis as was available for conventional cytology. A mean of 3.2 passes was obtained for conventional cytology and 1.6 each for DIA and FISH. All specimens were reviewed by cytopathologists, blinded to all other data. A gold standard was based on strict cytohistologic correlation and a minimum of 24-month follow-up. 250 patients were enrolled. 202 patients had a diagnostic gold standard, including a broad variety of biopsy sites and tumor types. Our data suggests a potential lack of utility for DIA compared to conventional cytology. FISH, on the other hand, provided a comparable sensitivity despite analyzing only half as much material. And when considering all potential test combinations, the performance characteristics were optimized with the composite results of conventional cytology and FISH. The addition of FISH increased the sensitivity over conventional cytology by 11%, which was statistically significant, increased from 75 to 86%. The addition of FISH allowed a diagnosis of malignancy in 16 patients who were missed using conventional cytology alone, but FISH was associated with a decrease in specificity from 100 to 96%. We concluded that FISH testing identifies neoplastic lesions with significantly greater sensitivity than conventional cytology in patients with diverse pathologies undergoing EUS FNA. Certainly further study is needed to verify the FISH utility and to determine the clinical and histologic factors that impact FISH interpretation to optimize patient selection. I'd like to thank the co-investigators for their work on the study and Gastroenterology for allowing us to present our data. Thank you.